All right, well, we'll get started. So welcome everyone to the Facilitating Safe Operations session. It's great to have you all here. We have some really nice talks from a really nice focus on basically experiences, examples, and tools that any organization can really use to help facilitate safe operation. And this is everything from, what you can do to help design safe practice principles to what you can do to be performing surveillance and identifying tests. So we should have a really nice range of topics to facilitate your own safe operations. And with that, we're going to go to our first talk, and there's a slight change in the talk order today. We're going to be starting with the first talk, which is Joaquin Lugo, who's an associate professor at Baylor University and is going to be talking about wastewater surveillance. So thank you very much, and it's all yours.
Right, thank you so much. Can you hear me okay?
No problem.
Okay, all right, so maybe just want to make sure. Okay, so I'll be talking to you about the use of wastewater based surveillance to monitor SARS-CoV-2 at a university population. I'm at Baylor University and wanted to give you just some brief background. So wastewater-based surveillance has been used for quite some time. And so it's been used for looking at other existing threats such as pathogens or also like things like a polio virus. That's been one where the Antigen 2013 was a really nice way where the Israeli government was able to monitor for an outbreak of new polio exposure and how they were able to follow it up with a successful campaign to suppress it. And then also in the age of COVID, very quickly after it was announced it was going to be an epidemic, there was a lot of information that came out pretty fast where you can use wastewater-based surveillance as a tool for tracking SARS-CoV-2. So a number of papers that came out pretty quickly after SARS-CoV-2 was spreading as much as we have seen over time. So in terms of the background for why this might be a method that works, so viral shedding, it does occur in the feces. And so there have been a lot of reports that have found that SARS-CoV-2 can be found in the human stool, and it can be detectable through PCR within 1 or a couple of days after the symptom onset. And one thing else is kind of interesting is that it appears for a long time. So even if you have a negative sample for nasopharyngeal samples, you can still see that the SARS-CoV-2 is present in the feces for quite some time. So it's pretty sensitive and also shows the duration for as long as the virus is in feces. Something else too is that they found it appears in feces within 3 days of an infection. And so for one, it's sooner than symptoms that are severe enough to send them to a hospital. So it's really getting at this. It may be able to detect while they're pre-symptomatic and not just when they're symptomatic. So it could be a way of looking at them at an earlier time point. And based on other work with SARS-CoV and also MERS as well, they've in both of those that were detected in the stool, both symptomatic and asymptomatic. Some of the work for wastewater surveillance is maybe a bit unclear as to whether it can detect asymptomatic, but it appears that it probably will be. So this wastewater surveillance is a very powerful way to look at how, what is the infection for those who are pre-symptomatic, asymptomatic, and those who are currently infected with SARS-CoV-2. So there's been some discussion and articles about, well, how sensitive is it? They think if 1 out of 114 people have an infection, it may be able to detect it. And that's one of the paper came out where it's possible if the conditions are just right, may be able to detect 1 out of 2 million people. And so it might be a way of monitoring a very large area or several different parts of a large city and see what can the detection be like. So it's a good surveillance for a large area because it may be that sensitive. So what I wanted to jump into, that's just kind of a brief background for the sake of time to kind of orient you to what this process is. But I wanted to tell you what we've been doing at Baylor University. I know there's been a lot of discussion about opening schools and stuff like that. And I'm in Texas, and so things are pretty much wide open. That's just what we do. That's our approach here. But one thing is, and where I got involved with this, and my area is psychology and neuroscience, but I have experience using PCR and stuff like that. And I wanted to assist with testing But we found we weren't going to be able to do like testing through my lab or through one of the labs here. So where I was asked to assist with is try to get sewage testing up and going. That way we can see that this could be a good way to monitor sewage in the campus and see whether we can detect SARS-CoV-2 and then be able to decide, well, how do we address that? Do we go in and test a lot more? Do we isolate? It may give us a broader way of surveilling what's the infection rate looking like on campus. And so this is an email that was sent out, I guess in August. I was looking into this in June, into this process. And then when it became more public was when, I believe it was in September, when then the local news let them know that we were monitoring sewage testing for SARS-CoV-2, one of the campus dorms here. And in fact, based upon individual testing and the sewage testing, they decided to quarantine or to kind of lock down some of the dorm floors to try to calm some of the infection that was occurring on campus. But I'll show you the data in a second. So for our surveillance, we've done is we really are monitoring 20 dorms around campus. And so we go throughout all the dorms and sample at those dorms. We initially did, this was before students were back on campus. We went to one of the dorms and there weren't many students on campus. For one, it was in August. And then two, just because of the pandemic, there weren't a lot of students on campus. But this was one of the few dorms that had some students on campus so we can sample from. So you go there, you open your manhole cover, you have this is a grab sample. And so you have a pole with a 1 liter Nalgene bottle. You basically stick it into the sewer, right? And you collect your samples. And so this is what's commonly known as for just grab samples. And so you're going in, really just grabbing a liter at a time and then processing it. And I can kind of answer questions about the benefits and some of the caveats of using that kind of approach. So, but for our study here, we did is use auto samplers. And so this is an example of an auto sample that's basically in the middle of the road because that's just where the sewage exits that particular dorm for it. And so they're enclosed here. They have housed all the bottles as well as there's ice in there to keep it cool and hopefully no one runs into it. Actually, I think we did have 1 or 2 that were damaged this past semester. But the way the auto samplers work is it'll pull in this container, it's an 18-liter container, and it'll have this composite samples. And so we decided to be the best time to collect for this would be over a 24-hour period between 10 o'clock in the morning Monday to 10 o'clock in the morning Tuesday. A lot of discussion about what time might be the best, but we decided that this was a good window of time to monitor. The way these samplers work, it collects composite samples in 187.5 milliliter increments every 15 minutes. So that way you are sampling across that entire 24-hour period. And then these are enclosed and to reduce any kind of photo degradation, during this time, they're kept on ice to keep the samples cool. And so what we do is we go around and pick them up and then you aliquot out what we're going to use for hours. We're not going to use the entire 18 liters. It's a lot to process. And so we really just processed 250 milliliters. And then we also saved a 1 liter sample to ship off to a company that was processing the samples for us. So once we have these, we have our liter container, we put it on ice and ship it out. And then what we did, we used a company called Serum, and they were the ones that did our investigation for the fall semester. And I'll go into where we transitioned from using this commercial company to doing it in-house. So they send you a report like this. It shows some of the quality controls that they do. So they look at the ORF1, and they also use the N gene and the S gene. They spike it with a known virus to make sure it's going through all the sample and you're not losing sample throughout this process. And on the right, it's actually using the N gene to say, what is the viral number of viral particles per liter is going to be the measurement. Okay, so let's end of this, and then this next one here is really showing what our data look like across the semester. And so we started sampling on August 24th, and then we stopped sampling. Basically, it was a Tuesday right before Thanksgiving, and that was because then the students were asked to go home because at that point things were going to be pretty high, and the data here kind of reflect that. So these are all the 20 dorms on campus. What you can see here early on is that there was a spike pretty quickly, and this is all the students are coming back to campus, And so what they did at this point, they really were pretty aggressive about the mask mandate and did a lot of things to really curb a lot of this. And this is where this early kind of time point where they went to individual dorms, did a lot more testing and did more quarantine of individuals, and they got pretty aggressive. And so what you can see for the remainder of the semester is that it really dropped down through the remainder of the semester and it sort of peaked back up, basically kind of in line with what we would think is like after Halloween start to go back up, and then as we got closer to the end of the fall, it really decreased. And this is across all the dorms. So I only kind of collated a couple of them so you can kind of see the ones that really kind of stick out. And for instance, like the dash one here, this is Martin. This is the one where we did have a floor of the dorm where they had to quarantine during that time, not leave their dorm room. And then what you can see is that, I mean, this gives you a surveillance of everyone, that it didn't, that and other things seem to be very helpful and really suppressed during this time until the very end of semester. Another way to look at this data is look at by dorm size. And so some of these dorms are a lot bigger, like Collins Hall house about 600, other ones house about 92. So you're gonna have a lot more virus particles in areas that have a lot more people. And so when you normalize it that way, you can see it picks up other ones where kind of this ratio here is in this particular place, NV University House, and also Brooks, per person seem to be at a higher rate. So one thing we can do is, we did have testing, like randomized testing over this time. And this is where you can this is just for the fall semester, where you can see the spike early on that really kind of went down across the semester, and then, students leave, and so it probably would have gone back up. But this is kind of in line with what we found with our sewage monitoring. So I had mentioned that what we really wanted to do is do all the testing ourselves. When you ship it off to a company, you don't really know all the things they're doing with. Not that we don't trust them, but we don't know all the aspects of their methods. Also, it's kind of a little expensive to do it that way. But like many of you, one of the big things was just the supply chain problem. We couldn't get the RNA extraction kit certain times, and then so there was just a big mess with it. So really, what we did during the fall semester was trying to troubleshoot to get everything ready so that when we do it in the spring, we're able to do it ourselves and be able to monitor it ourselves. And so at this time, we worked on sample processing. So we got our containers here and we would spin them down, 250 milliliter ones, spin them down. And so what you're going to do is get this pellet at the bottom of your container. You can kind of see here on the right where you have this is our very first sample, so they're quite clean. But you get this pellet here. And what you're going to do is pull the supernatant and then put into your Omicron filters. And this will help to concentrate your sample. That way you get a much more concentrated sample for what you're going to run for your RNA. And we then compared really all the procedures that we could find out there. It was actually quite difficult to know all the ones that were out there, but we compared all the different ones that we could. Initially wanted to use the Kaigan one, but we were supposed to get it in August, and then it was not August, it was October, and then it was not October, and then it was November until we finally got them. And so we're just kind of trying different kits during this time. What we found, and then we did all the different procedures for us, the Pcr analysis, all our data that I'll show in a second are in triplicate. We do standardized curves, so 8-0 resolution from 10,000 copies down to 2.441 copies, and compare it to that particular standard. And then did dilution factors as well, just to make sure there weren't inhibitors as part of the sample itself. That's what you see that in wastewater that could impact it. So, and I'm happy to go into more detail with this if you have questions about this later. But one thing is, and this has been a lot of papers about this, is you really kind of have to optimize what's best for your water at your institution, your wastewater. And for university setting, the way it worked out for us was that the Zymo research, the Zymo Enviro water RNA kit, was the most effective for us. It was much more sensitive in terms time-wise and everything, which has worked out much better given our particular samples. And that's what we're going with in the spring semester. So this is data from just last week. In fact, we collected other data Monday and Tuesday this week. So we'll see what it looks like on Thursday. We'll get the data for it. And so what you can see here is that there are some copies here. So it's relatively low at this point. And so what you can also see is that most sites are negative for them, which is great news. And so overall it's low compared to what it was in the fall. And these are negative. One difficulty in comparing is that it's a different kit, right? So what we're doing here compared to what was done with serum is not quite the same. That's why we really couldn't just in the middle of it switch from one to the other, because the data was going to be just slightly different between the two. And then if you normalize it per dorm occupant number, this kind of does pick up a few more places that may be higher than what they think they are. So we're monitoring this really across the semester and see, what the trends look like. Here at Baylor, we do have weekly testing that we're now doing. And so we'll be able to look at weekly testing along with the wastewater testing to see how close they are to one another, and hopefully be able to correlate what we see in the dorms to the individual testing as well. But that's done at a higher level. I don't get to do that, but that data will be available for those here at Baylor. Once again, this is across both semesters with it. So these kind of help you to give like a dashboard for what are things looking like, if you have interventions, what the impact may be. So some of the benefits of this approach is that you can do weekly surveillance. It's not cheap, but it's relatively, compared to testing every week, everybody, it's a relatively low cost. You can scale it to a larger area. And so there's now collaboration with the city of Waco, as well as some cities in North Texas, where you could run those samples here. And it's possible, there's one paper that came out that Kevin mentioned to me here, is that maybe you could be able to use wastewater to detect new variants and stuff like that in your particular sample population. So if you want to start wastewater surveillance at your institution, composite sampling is highly recommended. Otherwise, you're just sort of hoping you get lucky with the samples that you pull out, where you have to sample it several times, and it's a lot of work to do that. You really want to have all the reagents in place and see with the methods what's going to fit your institution's cost and timeline. Okay, so just there's a lot of us that are part of this project. Many of us, this is not a particular area, but this is an area that we decided to help with as a way of having surveillance of SARS-CoV-2 here on campus. And so I think I have a few minutes left, but I wanted to go over the approach that we took for surveillance on campus. I'll go ahead and stop the share.
Excellent. Thank you very much. It's a really great example and really nice to see how that's played out in Baylor. So if anybody has any questions, please post them in the chat. We will get to them. And also, please feel free to continue the questions and the conversations on the Slack, because we have a dedicated channel for sessions facilitating safe operations where we can continue this conversation. But to begin with, does anybody have any questions? Then I will actually jump in with one, which is, you mentioned a little bit that, Baylor is now doing, regular testing to go with the wastewater surveillance. So how are the different elements of sort of Safe Campus integrated? Do they play well together? How is Baylor managing all the different data streams and all the different components working together?
That's a great question. I don't know, is the honest answer. So this is kind of, I guess, above my pay grade, where I don't know what people above, and actually that's been one of my frustrations with it, is that I'm doing my particular part. I don't know what they do with it, to be quite honest. I'm hoping it's of high value, but that's where, and we have a variety of teams as a part of that. I'm not part of that team. So I'm not sure, but I know that they have, that's the plan, is to be able to use all this together. Our part is just to make sure that the surveillance is working. And then I guess another group that I'm not aware of who it is going to pull all that together.
Excellent.
There's not been a lot of communication, which is a little frustrating, but.
Also not atypical, but, a little bit disappointing when you have, really nice surveillance systems going on at the same time. So we have two questions in the chat. The first is, what budget line item did the university use to build this project?
That's a good question. I don't know. I know so the one who was involved with this is our, I think, VP of research for it. And so he's a chemist, and him and someone, and the ones I mentioned here, environmental science, were the ones that kind of spearheaded. From what they've said, they found funds as part of the surveillance, and then so that once again, that was not communicated, but they found funds somehow.
Yeah.
I don't know. We
A little
we got the money. I don't know.
creative accounting.
Uh-huh.
So another question is, do you have any thoughts or, is there any sort of trend to actually be looking at any air or surface sampling in terms of additional surveillance that could be done, air sampling in classrooms or things like that?
Huh. That's a good question. I've heard no discussions for that. Um, I know in all all the buildings and all of the rooms, classrooms, they all have the alcohol wipes and stuff like that, and everyone's encouraged as they walk in to clean the surfaces, and as they leave to clean the surfaces. As the instructor, I clean the surface after I leave and stuff like that. And so the hope, and they go around cleaning them all the time, but they've not monitored it. To answer your question, they've not been monitoring it.
Right, right. And last question is that, where does the composite sample come from exactly? And is that a difficult part of the process?
Yeah, so the auto sampler is there's basically like a tube that sticks out and goes into the sewer, and so it just pulls every 15 minutes. And so there's a battery pack with each one of these, and it lasts about 36 hours. That's why 24 hours is sort of where you want to aim for. But the auto samplers will do that for you. As long as it's positioned correctly, it'll pull up because 187.5 milliliters every 15 minutes, and then you have this composite of across the 24 hours.
Excellent. Thank you very much.
Sure.
So please, we'll continue on any questions on the Slack channel, but for now, we're going to move on to the next talk. So I would now like to introduce Kevin Schallert, who's the co-director of the National Scientist Volunteer Database, and is going to be talking about that very database, the creation, operation, and what they've been able to do with this absolutely incredible volunteer resource. So Kevin, it's great to have you here.
Thanks, Jeremy. And thanks everybody for joining. It's an honor and pleasure to be here. So we're going to talk initially about what NSVD is, how we got started, what we do, and then the process for us to help any of you if we can be of support. Dr. Mike Wells, who's the founder and director of the project, sort of started this whole thing by putting out a tweet back in the middle of March, and within a couple of hours it had been retweeted by a few people, and the first night the database had about 4,000 people in it, of scientists that it wasn't clear how they would volunteer, how they would be able to use their skills to help their community, but they were communicating that's the thing that they wanted to do. And so with that, Michael started working on putting together, like, answering the next question is like, what do you do with all of this information? It wasn't totally clear if there was just a decision maker that you could give it to, and then they would operationalize it. I think we found out pretty quickly that wasn't going to be the case. So over the next couple of weeks, Michael and then several people on this call and dozens of other people throughout the scientific community volunteered their time to take on coordination roles and try to operationalize the database. So you can see in this map sort of where the volunteer records of, we're up to about 10,000 volunteers, sort of where they are geographically. And so the group has been sort of under the umbrella of endcoronavirus.org, although also kind of independent, but we certainly use the resources of endcoronavirus to build stuff out. So what the database does is connecting all of these rows of scientists to help with COVID response. So the big primary goal is supporting decision makers, both in providing resources to be more nimble and deploy actionable, like, boots on the ground projects. Running community labs is sort of the initial thought of how to use the database when there was a shortage of bench scientists, and saying we have these bench scientists, we can get them there. But then we've become kind of creative as we've gone on. So the coordination team works a lot on sourcing opportunities. So if any of you have interests in using professional scientists to do COVID response, certainly get a hold of us. We also try to be a clearinghouse for what's working. that uses scientists. So that both helping scale individual projects and especially replicating successful projects that we see that happen at a local level that might be really labor intensive, so they don't scale well. But if other motivated people in different geographies get into them, they can work quite nicely. And I think the last thing that we really focus on is when we deploy our scientists to try to do it sustainably. We find that there's really high attrition if it's sort of non-defined end date. So we look at projects that the expertise can come in and really get initiatives going, and then naturally move on to either staff roles for the scientist or build it out to locally controlled, locally managed initiatives. So what we don't do is we don't charge anything for service. At this point now, more than 6 months in, I think our total budget outlay is $15 for a website, and we haven't taken in any revenue. So we are in the red, but I think we can handle it. We're not an advocacy organization, so we think that we're best able to support decision makers if we don't take positions on what they're doing. There is some exceptions where we try not to provide advice or position our scientists to provide advice that can risk people's lives, even if it's supporting decision makers. And so we had some of that conflict with the going back to school, where we're happy to support the science for surveillance, but the guidance that enabled risky behavior, we try to push back on a little bit. We also don't share our records with commercial entities. You can see our terms of service on the website. And the last one, which is kind of a tricky one, is we don't conduct basic research. We don't have independent laboratory facilities. So we get a lot of requests for, this would be really cool, you guys should do that. And so if there's not a project already going that we can put people in, we really struggle to operationalize that type of request. So here you can see kind of a breakout of this skill set and the different scientists. So we sort of mix between being academic scientists, a lot of postdocs and grad students, as well as industry scientists. And sort of that mix of experience has helped us provide services for a variety of different groups, both for-profit as well as nonprofit. And then the questions that we asked in the database are focused towards bench science skills. So we've got a lot of data science and visualization and quantitative skills that we didn't ask necessarily as much about, but we can find those questions out, especially when we have specific requests. So coming into like how we can help you, it's pretty broad, and we encourage people to be creative with where we can be useful. Like here on this list, you can see sort of examples of what we've done. We've helped pop up wastewater surveillance projects, both bringing in scientists, as well as the org, insurance, and indemnification aspects. So we try to tackle the hardest parts to make it so operators can focus on the really meaningful stuff. The pro bono consultancy work, a lot of it ended up being data analytics. We try to find out what decision makers want and provide that service rather than just work on the projects we're most interested in. And then science communications, we've got a really vibrant comms team that can help communicate both to decision makers as well as to members of communities. So we can also help with assay development. And then I guess based on everybody being here, you're already kind of plugged into some of the different orgs that are working on coronavirus response. But we've got a great relationship with some groups that are doing very specific and then also broader type response stuff. So if there's areas that we can't be as supportive, be it advocacy, bringing in people from the health sciences, or like the venture capital type play, like we have partners that are more naturally suited for those. So even when requests come in that we're not the best suited for, we try to put introductions to where people can collaborate with their community. So if you want to get involved, either as a scientist or if you think you can use us as a resource, we're certainly eager to do it. As a coordination team, our key metric for success is how are we getting our scientists to do work where they're both personally fulfilled and making an impact. So if you go to our website, which is covid19sci.org, you can hit the Need Volunteers button. There's a quick preview. Somebody on our team will have a chat with you, and we'll get you, if it's the right sort of relationship, and we'll sort of talk through what makes sense versus not. We will get you contacts to the scientists in the database, as well as tips on how to use it effectively. There's also a data studio instance on that website, so you can get in there and sort of peruse the different information, see what scientists and what skill set might be in your geographic area. So that's sort of the gist of what we do. If you want to get a hold of us, that email on the top is sort of a landing email that's checked pretty frequently. You can also reach out to me directly, go to our website. And if you want to get involved from a coordination perspective, or if you just kind of want to audit and just have visibility into what we're doing, we kind of live in the endcoronavirus.org Slack. And so there's a channel there. And so we encourage everybody to join, both to work with us as well as the folks at End Coronavirus, because we find there's a lot of crossover for both of our groups. So it's been a really mutually beneficial relationship.
Thank you very much. So do we have any questions for Kevin or about NSVD in general? And I don't particularly, this isn't exactly a question, but it's just a little lead in, which is just to say that the next two talks are going to be two really good examples of where NSVD collaboration with different organizations has really led. So coming up, you'll see some really good examples. We have a question, which is, how many projects have been worked on so far?
Dozens. I don't have a hard number. One of the things that we do is from a national level, we've really pushed as much stuff as possible to our local organizers. So they're fielding probably in the low single digits of requests every week. And then from the national group, we take the ones that we think that we can replicate to other areas as well as scale. But we've deployed over 1,000 scientists from the national level, and probably a couple times that level on the local, though those are total opportunities. There are some of the volunteers, a small percentage of the volunteers probably do a lot of the total work. You've got Vincent and Jeremy on now, and they've both been on dozens of projects helping and supporting NSVD initiatives.
So do you have connections and work with other, other national or other international volunteer scientist databases or other volunteer scientist programs?
So there's some local volunteer groups, particularly the one in UCI in Irvine, as well as the one out of University of Madison in Wisconsin, that were already mature when they sort of joined with us. So those groups we've sort of partnered with, and they've got their own much more robust org structure than some of our other local organizing groups. And then there's a similar group in Canada, as well as one in the United Kingdom, that we don't work very closely with, but when there's appropriate opportunities on both sides, we have good enough relationships with that we sort of pass off those opportunities to one another. We haven't done very much international relief work, not because we're against it, we just haven't seen the opportunities, but with the amount of remote work that we've done domestically, there's no reason why we wouldn't be able to service any requests outside of the United States as well.
Excellent, thank you. Do we have any other questions? And as always, please continue to follow up on the Slack channel for more questions or discussion, or to get involved and reach out to NSVD. All right, so with that, I'm going to do the unusual thing, which is turning it over to Kevin to introduce me.
Well, this is the most exciting part of my entire day. I think if we were going to give out COVID medals of service for like the response here, Jeremy would be the first on the list to get one. He's a virologist at the University of Kent. He runs a humanitarian aid network called Research and Aid Network, And he's also really helped us as a member of our leadership team at NSVD. Today he's going to talk about surveillance testing broadly, what some of the advantages and risks are, the modalities that make sense, as well as this particular protocol that he's worked on that might make sense in your community. So it's my pleasure to introduce my friend and collaborator, Dr. Jeremy Rossman.
Thank you very much. And it's my pleasure to talk to you about community surveillance and sort of what any community-based organization can really be doing. So with that, all right, so I'm going to start fairly general, and I'm going to give a little bit of an introduction to basically testing, how that can be used in a community setting, what the different testing options are, with this idea that what we are really trying to promote is we're really trying to promote awareness of testing and the ability for any community-based organization to be able to say, yes, I would like to start doing routine testing. This is how I'm going to do it. I'm going to reach out and the NSVD is going to help me, and we're going to make it happen in a low impact to the organization way. So, all right, to get started, all right, I have a video here that maybe some of you have seen from early on in the pandemic. This was a nice example of a video that was made looking at how social isolation can act, sort of social distancing can be really effective in stopping virus transmission. But actually, it's a great example of the role of testing. So this is the video. So the idea here is that these balls are all just individual people. You have one infected person coming, one infected person infects multiple people, which then infects multiple more, and it just escalates like that. But if you have one infected person coming in with distance between these people, then the virus doesn't spread and you can stop the transmission. So in this case, this example is really focused on that idea of social distancing between people to stop the spread. But what also works extremely well, and perhaps even better, is if you stop that ball before it even gets launched towards those mousetraps. And that ball is the infected person. So the quicker you can identify anybody that's infected, get them to isolate and remove them from the population, the transmission chain, the better you're going to be able to stop the spread of COVID in any community. So looking at this graphically, this is just a little chart that's saying, you know, one person can infect several others, who then infect several others, who then infect several others, and it just grows like this. But if you have testing, then you can identify people who are infected and stop them from then transmitting and spreading to the next person. And so then instead of having this increasing number of cases, you start to decrease the number of cases. So how do we do this? Well, testing. So testing is a really broad term because actually there are a lot of different tests and a lot of different ways in which you can identify somebody that might be infected with COVID-19. So I'm just going to briefly run through the different tests so you have an idea of the breadth of options that are actually available here. So first of all, there are symptom tests. This can be something like an app, self-reported app, where it asks you some questions and you just report, you know, do you have a fever? Do you have any changes in smell or taste? You know, how are you feeling? Okay, these are pretty easy to use, but they're not particularly very accurate. You can also do temperature checks, but these have really been phased out because they've been shown to not be actually very good at predicting who is actually infected with COVID-19. More recently, we've started adding on smell tests or olfactory tests. And this is basically focusing on the idea that one of the first symptoms people tend to exhibit, and very commonly, is a change in smell. And so this test uses dedicated compounds that are really good at assessing any changes in smell. So this is yet one more new option. Now, antigen tests are something that we're all hearing a lot about. These are really what you think of when you hear of the idea of rapid tests. And this is an example of what an antigen test looks like. This is a very simple test that uses a nasal swab and then is added to the test. And it's basically very similar to a pregnancy test, where you get one line that shows up that says the test works, and you get another line that shows up if in fact you're positive. This is a 15-minute test, very easy to implement, but it is not quite as accurate as the molecular tests. And these tests are the gold standard tests. This is RT-PCR, for instance. And this is the gold standard. If you go to your doctor and you say, I've been exposed, I'm worried that I have COVID-19, this is what they will do. They will do a swab and they will test you by RT-PCR to see if you have COVID. And these molecular tests are very different from the antigen tests, because the antigen tests, what they're doing is these tests are looking for the presence of virus, whereas the molecular tests are looking for the genetic material of the virus. And they do that by actually amplifying the genetic material. So what that means is that they're really sensitive, because the antigen tests, they don't amplify anything. They just tell you, is it there or is it not? But the molecular test can take a very small amount and amplify it enough that you can detect the signal. So you have RT-PCR. You also have rapid point of care RT-PCR. These are things like the Abbott ID Now system that can give RT-PCR results within an hour. Both of these RT-PCR systems are really quite accurate, but some of them can take a long time to run. Sometimes they have to be sent out to companies to do the testing, and that can take multiple days. And the instrumentation is incredibly expensive. So like this RT-PCR machine is not something that any school or community service organization would just be able to afford. So that limits the testing a little bit. We also have a new technology called RT-LAMP. And if anybody saw Ed Campbell's talk from earlier in the day, this is the system that he's using to do testing within schools, because this is a simplified version of RT-PCR that's still quite accurate, but doesn't require quite the same level of complicated and expensive instrumentation. Now, with any of these molecular tests, you have all these different flavors. So you have these NP swabs, and these are the swabs that they stick so far back into your nose that it feels like they're taking a chunk of the brain with them. You have AN swabs, and these are the swabs that sort of we're using a lot more these days, where they just go partway into the nose, isn't nearly as uncomfortable. You can also do testing with saliva. You can do pool testing, where you take samples from, say, 5 different people, run them all at the same time, and get one result for all 5 of them, which allows you to actually test more people for the same cost. And then, as we just heard, you can also do wastewater surveillance to really test for the presence of COVID at a community level. And of course, many of you have heard of antibody tests or serological tests. Now, it's just, I want to note here, because antibody tests do not detect whether you are currently infected. They detect whether you have been previously infected. So when we're talking about community surveillance, we're talking specifically about these tests, the symptom tests, antigen tests, or molecular tests. So where do they come into play during the infection process? So over here, this is called the viral load. And what we mean by viral load is just how much virus is in the body. So when you get infected, you start out with a very low amount of virus, and the virus is very good at growing in your body. So the longer time goes on, the more virus that you have in your body. And it takes a little while before you get enough virus that you really start to be able to infect others. So you get to this point in time where your viral load starts to become quite high. And that's when you start to have symptoms. But that's also when you start to be really highly infectious. So these are the people that we really want to identify and isolate so that we can stop the transmission. But COVID-19 is really difficult, because if you look here, this is where symptoms start. But you see viral load is actually quite high before you get symptoms. And this is really problematic because that means if you're only looking for symptoms, you are going to miss days in which an infected person might be able to transmit the virus. So basically, if you look at this curve, the earlier on this curve we can identify a person and start isolating, the better we're going to be at stopping community level transmission. To do that, you need to be testing regularly. So this is just an example of where the sort of two main types of tests come in. So this is PCR tests, and PCR tests, or the RT-PCR tests, as I said, are really sensitive. So they start detecting the virus really early, well before you have symptoms, and they can often detect the virus way late, even after you're no longer infectious. So they're incredibly sensitive and incredibly accurate. Now, that's great in and of itself, except that often what we hear about for PCR testing is a 2 to 3 day turnaround time from when the tests are taken to when you get the results. So that might mean you get the test here, but you don't get the results till here. And that means you miss this whole period of infectiousness. Now, antigen tests are different. They're not as sensitive. So they're not detecting virus down here, they're detecting virus up here, which means they don't detect virus quite as early as PCR tests, but they're really good at detecting the people that are quite highly infectious. So there's this interplay between how sensitive the test is and how frequently you're using the test. And so this is an example. This is a figure from a paper. It's got a little bit more information than you need to know. So I've just simplified it by over here labeling this as just symptom testing. So if all you're doing is saying we're not doing any testing, but anybody that has symptoms, we're telling them to isolate. Okay, well, that's the first category. The second category is what happens if you do PCR testing. And the third one is what happens if you do antigen testing, which is not quite as sensitive. So if you're only doing isolation following symptom reporting, well, you're not very good at removing the infectious people from the population because it happens so late and it's not very sensitive. But if you do daily testing, well, it doesn't matter if you're doing PCR testing or antigen testing. If you test daily, it's really effective. And interestingly, even if you start testing only every 3 days, the difference in effectiveness between PCR testing and antigen testing is not really very great, because the important thing is catching people that are infectious early. The difference that the PCR testing gets you is a little bit, but it's not as significant as what testing all the time gets you. So ideally, what we would have is a test that's incredibly sensitive and cheap and available to run every day. Unfortunately, that's not what we have. So why don't we have regular community-based testing? Why don't we have PCR testing that every community can do daily? Well, first of all, the infrastructure that we have has been historically focused on clinical testing for symptomatic patients. And this is because from a medical perspective, this is what's really important, is if you're going to treat somebody, and if you're worried about somebody having to go into the intensive care unit, what's really important is saying, well, okay, do they have symptoms? And if they do, are they infected? So there you want a very different kind of test than you would want if you're just looking at the population as a whole and saying, it doesn't matter in this case if they have symptoms or not. What we want to know is, are they infectious or not? And so in that case, we're talking about surveillance or regular population level testing. And unfortunately, there's no regulatory framework for that. And that has really hindered the development and the licensing of tests for this regular community level testing. As part of that, the tests are quite expensive frequently. If you use a service to do the testing, it often has multiple day turnaround times, and that really limits how effective it can be. Antigen tests are great and can be fairly low cost, but they often have very limited ability or can only be used in specifically regulated frameworks. Now, we may feel like we're at the mercy of the regulators and the government for these, but in fact, this is driven by public support and public demand for testing. So the more we are all saying, look, we want regular community level testing, and the more organizations are pushing for that, the better we're going to be at getting that to happen. So with that introduction, where do we stand? So if you're a community-based organization, if you're a school, if you're a community center, if you're a social service organization, if you're a care home and want to do testing, well, what can you do? Well, there are a wide range of things. You can do PCR. You can hire a company to do the PCR testing for you. It's really easy if a company does it for you, but the sensitivity is great, but the costs are really high. So, and the turnaround time can be low. If you want to do it yourself, well, that's great, but it's really expensive. So if you want to go an antigen test, well, okay, that's great, because then the costs are low, the ease of testing is not too bad, it's quite effective in removing the infectious people, but there's a problem, is you often have to play into this specific regulatory framework in order to access these tests. So it's a problem. Because of that, one of the things that we've been recommending is this sort of on-site, almost do-it-yourself RT lamp assay, like Ed Campbell was proposing, where it's a relatively easy test. It's quite sensitive. It's not terribly expensive, but it's got a really fast turnaround time. So you can actually get the results and act on them very quickly. There are also things like olfactory tests that we're getting more information about that are really easy to use. They're not quite as sensitive, but again, if you're testing and using them every day, they might be really effective at identifying who's infectious and trying to get them to isolate before we get community level spread. And of course, there's self-reporting, all these apps, which is better than nothing, but their sensitivity is extraordinarily low, and the time frame in which you get the results that you can act on is really late. So they're not really good at identifying who's infectious and stopping further transmission. So this is all a playoff between all of these different pros and cons, and it makes it quite difficult and quite confusing. And often community-based organizations would look at this chart and say, well, there's no really good option. How do we go forward? So, well, how do you go forward? That's where we come in. We're here to help you. So NSVD and Research Aid Networks has developed this community testing initiative. And the idea here is really to use all the resources of NSVD to really help community-based organizations to be safe. And this is both consulting on safe operations. So like, what do you do for ventilation? What do you do for how many people you're going to have in a room at one time? When do you do testing? What kind of masks do you use? Anything that you need for safe operation. We'll also consult on testing options. We might have some options that we think are good ideas, but we'll run through all the different options with your organization to say, look, these are the pros and cons, and this is what might be best in your situation. And then we'll help you do it. We'll help you set up that testing system, from designing your testing program all the way through implementation, whether that's helping you get things like CLIA waivers so you can do antigen testing, or helping you set up an on-site saliva-based RT lamp system, which is one of our options that we think sort of meets that middle of the road of wanting sensitivity, ease of access, low costs, and quick turnaround time. But there are a lot of options that we can help set up for you. And we really are designed to provide full assistance, from just the idea of saying, would like to do some testing, all the way to having data in your hands and being able to make informed decisions that help keep your organization safe. So that's what we do. But there's a caveat, because testing is not a miracle cure, and testing needs to be taken in context. Because all COVID tests, whether it's an RT-PCR test or an antigen test, are red light tests. They're not green light tests. The test will not tell you that it's safe to take fewer precautions, but the test will tell you that you need to take more precautions, that you need to start isolating because you might be infectious. The testing needs clear communication with the public, partly to explain how testing works, but also what testing actually tells you, this idea of red light tests and not green. Of course, testing requires buy-in. The community members need to get behind this because people that are positive then need to isolate, and ideally will get community support to help facilitate that isolation so that they're not further disadvantaged. And of course, testing is an effective added layer, but it is an added layer of precaution. It's not a substitute for any other individual or public health measures. But on top of these other measures, it can be extraordinarily effective. And this is what we're trying to facilitate for community-based organizations. So with that, I'd just like to say that if you're interested in doing community-based COVID testing, whether you're representing a school, a community-based organization, please get in touch with us. We can help. We're here to help. So thank you for listening. And with that, does anybody have any questions? Okay, so I do have, let's see, I have one question, which is how much do antigen tests cost? So yeah, this is a really important point that I didn't really get into, is that, you know, antigen tests are so different. There are so many different variants, and they differ really significantly from each other. So some antigen tests are really good at having quite high sensitivity, like Binax Now, and some have been reported to have lower sensitivity. Some are in the sort of $15 to $30 per test range, and some are in the sort of around the $5 per test range. So they really vary. And this has been sort of a problem with the regulatory framework too, is that because the tests have been, the way they've been licensed has made it really difficult to make the cheaper versions of the test. But we're starting to get cheaper versions. And I think over the coming months, we will get further inexpensive versions. But for right now, we're talking anywhere, say, from $5 to $35 per test. So let's see, I think we've got just about 1 or 2 more minutes here. And yeah, so tests based on exhaled breath. Yeah, so this is a great question. And it's really interesting because I gave you a really brief sort of survey of the tests. But in fact, I didn't really do that justice because there's a lot more tests and a lot more testing types than what I showed. So breath tests, there are actually, you know, dog training programs that have gotten dogs to detect and smell people that have COVID. There are tests using this technology called CRISPR. So there are actually a lot of tests, but the issue is that many of those other testing formats are further downstream in the evaluation process. So most of them don't have EUAs right now. We're further along the lines of being able to say, okay, if a school wanted to do it, would they be able to? And often for those tests, the answer right now is maybe they could get involved in a pilot program, but they probably couldn't do it at scale. And so, you know, maybe in a month that will be different, but what we're trying to present here is the tests that at some level, any community-based organization could do at scale and could do at scale now. So let's see, I think we got time for 1 or 2 more questions. So similar international efforts. Yes, so there are a lot of organizations that are promoting testing. and promoting this idea of community-based testing. So for example, rapidtest.org is a great organization for really promoting community-based testing and promoting this idea that testing at high frequency is more important than testing at high sensitivity, although ideally would be testing at high sensitivity and high frequency, but that's often not a possibility. So there's a lot of promotion about that. Michael Mina from Harvard has been very vocal at trying to promote this and getting more traction for this rapid testing. And so there's movement, and there's international organizations in many countries that are promoting this. And of course, the regulatory framework is very different in many countries. But we've been talking earlier in the day about equitable vaccine access, because that really varies from country to country. And a lot of countries that are not as wealthy have had difficulty in getting access to the vaccines. And so this is the same thing, is that the regulatory framework, but the access to these tests varies significantly from country to country. And my hope is that it will become more and more available, both in the US as well as internationally at affordable prices, so that we can do what is one of the core fundamental pillars of public health international epidemic responses or pandemic responses, which is to identify who's infected, because it's really difficult to stop a pandemic if you don't know who's spreading the virus. So with that, I'd just like to say thank you all for listening. And I'm now going to remove myself from Spotlight, and we will turn the talk over now to our last talk for the session, which is going to be a panel session. And this is going to be a really interesting talk, because this is another example of what NSVD has been able to do working with the community. Now, we're frequently talking about communities in terms of geographical communities, or communities in terms of, like a school or, a specific organization, but you could think of a community in a community of practice. And so this is a great example where NSVD has collaborated with the beauty industry to really examine the safety protocols and really try to figure out in a collaborative process how to design safe practice guidelines. And so it's now my pleasure to introduce the makeup standard group, Vincent Law, Danielle Dewall, sorry, we lost it. Mary Irwin and Lindsey Williams. And let's see, we will put everybody on Spotlight here. And thank you all very much for coming today. I'm really pleased to have you all here. It's been a really interesting journey, and I would just love to hear your perspectives of what the process was like, what you learned, how it was working together in this collaboration between science and the beauty industry. So thank you very much for being here.
Thanks, Jeremy. I guess maybe I'll let Mary and Lindsey introduce themselves, and maybe they can talk about how they came about to reach out to the scientific group and help them with their industry.
Sure. Lindsey, did you want to add anything, or should I go ahead?
Go for it.
Okay. So my name is Mary Irwin. I'm a professional makeup artist based in New York, and I'm the co-founder of the Makeup Standard along with Lindsey Williams. Lindsey and I work in the commercial makeup world, which encompasses working on photo shoots, on film sets, in advertising, in fashion, etc. Within this world, there's no legal barrier to entry. So anyone tomorrow morning could wake up and say, I'm a makeup artist, and start doing makeup, which is both wonderful and terrifying from a sanitation standpoint. To work in a salon, you have to have a license, but to work on set, there are no licensing or educational requirements at all. Lindsey and I both have very scientifically based ways of working, but for the general public in our industry, there were almost no guidelines for COVID safety when we started this project. We saw a lot of bad information being spread online. We saw predatory marketing. We saw a lot of things that shouldn't have been happening. And we just wanted to counteract that with actual science and not just opinions. We wanted to know how to work safely because there was virtually zero quality guidelines for freelance makeup artists as opposed to the salon world. We both were reaching out to all of our healthcare connections, and I ended up speaking with Vincent, who connected us to the NSVD, and they took us on as a consulting project and put together a really incredible team for us. We had crowdsourced over 150 questions, ranging from, we know this is wrong, but it would be helpful to have scientists tell us why it's wrong, to, I have no idea about this because I'm not a scientist. And they took all of the information that we gave them. We gave them over 150 questions and video. And we had several months of back and forth and Zoom calls and Google Docs and just translating scientific speak into artist speak. And we took all of that. We released a 15-page guidelines and a risk reduction infographic that both have been downloaded several thousand times now. Our Instagram has over 2,500 followers, including some of the global creative directors of multiple cosmetics companies. And I'm starting to have models tell me that they see our recommended guidelines being printed out and brought to set, and they're starting to see artists use the information that we in the NSVD have put out. So it's given all of us, just our talent, our clients, and us just peace of mind, knowing that we're doing all that we can to practice risk reduction and to be as safe as possible using science with the help of the NSVD. So that's us in a nutshell.
Hi, I'm Lindsey Williams, also a makeup artist in New York City and a hairdresser as well. So I actually carry a cosmetology license, and just like Mary was saying, there's no oversight for makeup in our industry. You know, if you carry a cosmetology license when you're working in a salon, you have governmental oversight. So if you harm someone with shears, chemicals, or whatever, someone's going to come for you for doing for doing harmful things. So in our industry with makeup, it's just kind of the Wild West. And we all felt it during COVID, especially during the beginning. Obviously, we needed to stop. We knew that our face-fronting contact with clients, with models, talent was very dangerous. And we didn't know where to go. We could do as best we could, but we knew in our guts it was not enough. So like Mary said, we reached out to the NSVD and we were just like, at first it started as a personal project. We were like, well, we're just curious and we need to know this for our own peace of mind. Just let us sleep better at night. And as they came out with all of these answers and just embraced us, which was really amazing too, because, you know, as makeup and hair in our industry, we're not always seen as the brightest bulbs in a box. We're not always seen as, you know, intellectual or intelligent. And, you know, we're just, you know, we like to play with pretty things. And so we were very moved by the fact that the NSVD just embraced us and we're like, yeah, let's get into this. And they very quickly started to dissect all of our questions and bring the best answers forward. And even in times where we got, they would come back with answers and we'd say, look, no artist is going to do these steps. They're too difficult. They take too much time. They're expensive. So what else can we do? And they were gracious to go back and figure out what else could we do that would also be equally safe, but also be attainable for artists. Because again, like I said, we knew our community and that we would face a lot of resistance. So we appreciate all of their generosity, their patience with us. And as this thing grew, like Mary said, we had 15 pages that we pulled together, and we still have more coming. And we were just taken aback. And again, getting it out into the community, it was embraced so quickly and kind of blew up. And people were really pulling into it because there's a lot of predatory marketing that's going on as well in our industry, where people are charging for information on how to be safe or safer and how to use sanitation practices and what do they look like. And we have found out through discovery of people who've taken these paid courses that are very expensive, it's very minimal what they're telling people to do. I mean, I knew pretty much everything that was being told based on my my cosmetology license. And so to be able to put this together and give it to people for free, we call it philanthropic work right now. We are not making money on it, not one dime, and we are just as passionate as the day we started to get this as far as we possibly can and to keep at it. I have no intention, neither does Mary, to stop it or say, well, it's complete, bye everybody. You know, we really want to be here through the long haul and continue updating it and be a resource for the makeup and hair, any part of the beauty community, to be able to carry this forth and bring it to set, bring it to their directors, bring it to your, even your managers. If you work in a salon or at a beauty counter, print it out and bring it with you. We're very happy to have you do that. Thank you.
And I just like to say this is one very good example where I think the scientists can be involved and collaborate with industry leaders and help them with these COVID safety guidelines. And makeup artists is one of those industries where they deem the staff and workers are deemed non-essential, and it seems like, you know, they're not important enough to provide a standardized guidelines for professionals that are in that industry. And I think Dr. Danielle DeWall here can attest to that, because we did some literary search, and maybe Danielle, we can cover some why we thought this was very important and there's not enough basic science.
Yeah, for sure. I can just kind of start off by saying my little story, how I got connected with NSVD, which is like so many others, early in March when COVID came, a scientist friend of mine, Dr. Brenda Curtis, sent me the sign up. And so I signed up and waited a bit and finally got some more emails on how to get involved with some projects. And when I took a look, I immediately was grabbed by this project because it actually means a lot to me personally. I played kind of a unique role on the team because I not only have a scientific background, I have a PhD in biochemistry and molecular genetics and spent a total of maybe 12 years professionally between my graduate work and my postdoc work, you know, in cancer biology and cell signaling and cancer metabolism, where I did learn to work with viruses. And so I knew quite a bit about the viral end, but I also have a cosmetology license, which I've carried for about 22 years. And so kind of had a way to kind of see things in a unique way, having done makeup, not quite on the level of Mary and Lindsey, but just doing makeup for clients before in the past, seeing how things were done, and just kind of, it was a bit of a pet peeve, some of those things. So it was really a pleasure to be a part of such a meaningful project that really is very impactful, I believe. There's a large amount of people in the industry, and as you guys have kind of touched upon, we kind of aren't considered critical, so maybe not as important, but it is important in our everyday lives. And we were, as a scientific team, working together to kind of address all of the questions Mary and Lindsey came to us with. We studied all their videos and got a very detailed analysis. We met many times, and we were really trying to go through this material quickly so that we could get this information to people in a timely manner. And we started searching, and we found very limited literature, which was a surprise to us. And so we've been working very hard to kind of promote these concepts to people because they work. They're very you know, our scientific minds all went very hard at work in these very detail-oriented protocols. And we were just really surprised to kind of push that information. It should be a high priority in today's world. And so that's kind of a little bit of how we all started working together on all these issues that still continue. You know, we have updates to work on, and the makeup standard has done such a great job at promoting this too. So good job to you guys for that.
Yeah, I'd like to also add in addition to Danielle and myself, Jeremy, who's the virologist, he's also involved with this project, and Kevin, who's on this call, as well as Gary and Taryn, who's not on this call today, but so the scientist team from NSVD had helped formulate this safety guideline for the makeup standard. And I think that, you know, this is I think this is not just for the beauty industry, but we should be promoting science-backed information in all industries. So I think this is one great success story how the scientific community can come together and collaborate with people from that are not in science community. And I don't know if Mary and Lindsey, do you want to share maybe some of the feedback from people who have used this mass doc, and what's your feedback on the mass doc? Like, have you been utilizing this religiously to while you're doing work?
I mean, yeah, absolutely. I've been working on set since July, and so far I don't have COVID, so yay, it works. But I do know clients and models, I mean, talent especially, because talent works with so many people. They could work with me today and be perfectly safe, but they could work with somebody tomorrow who has atrocious sanitation practices. And then in a couple of days, they could be carriers and work on another set. I have had jobs where the job itself is canceled because half the crew has come down with COVID. So it's knowing that we're doing everything that we can to work as safely as possible, because there is no 100% safe. I mean, 100% safe is staying hidden in your home. So that's why it's literally the risk reduction guidelines. But talent notices, producers notice, photographers notice, and it's definitely gotten me referred and recommended on several jobs that people can't do because they know that I'm going to do the best I can to take care of not just myself and not just the talent, but the entire crew. Lindsey?
Yeah, I was going to say there's such a safety in having the standard, because I found that I have a much stronger voice when I am on sets, when I'm with someone who wants to be difficult, who decides that they want to wear a chin strap instead of a face mask. And I will whip out my printed out mask document and be like, why don't I read you a little story? But it helps to, I think, in our full community, because we don't have that much backing or oversight. It's great to have something that is science backed. We have had very minimal, but of course, there's always a few haters when you start something, especially our industry can be incredibly petty. And when we started this, when we launched this out, we had a couple of people that wanted to push back on very small little things. And having the NSVD to be able to, I feel like we're kind of like just the storefront for the NSVD's work, because that's really what it is. And so it's been great that we could go to them and say, look, we have people asking these questions that we haven't fully covered yet in the mass document. Can you guys help us to answer them? It's because we're the conduit. We don't profess to be scientists. We do not know all of these things. We did not come up with these ideas or the entire bulk of this work. They have been our support system. So it's helped us to also have a much higher platform in our industry and setting us apart from a lot of these other things that are going on, because they tend to be more opinions, or we think that's what's happening, but a lot of guesswork. So I'm very proud of this work, especially with you guys. It would not exist without the NSVD, and it wouldn't have become what it is without the NSVD. Like I said, this was kind of just a pet project for Mary and I to feel that we were being more safe. But the larger it became, we knew that we couldn't keep that secret. We couldn't just keep it to ourselves. It became a burden of information that we had to share with everyone.
The other thing about what we did with the makeup standard is that we are the only source of scientifically backed information that's not behind a paywall in the entire industry. We're the only ones. And it's amazing how many people have not necessarily used it as an opportunity for self-promotion, but used it as an opportunity to make some money.
Yeah.
And our personal feelings were that this is a public health issue. And if at some point there's a way to turn it into a money-making operation, great, but safety is the ultimate concern. And I think that's the ultimate concern of everybody who's here today.
Yeah, and not at the behest of people, and we want people to be able to receive this information no matter your station, no matter your income level. Some of these courses and classes are so expensive that, again, it's unfair. If you can't afford it, you can't be safe. Like, that's absolutely, it's ridiculous. So we're really proud of it. Like I said, we encourage everyone to go to the website, themakeupstandard.org, take a look around. We also have it in Spanish now, which I'm really proud of. So we've been able to get it out to even further, a little more international, and continuing, we're always looking for help to be able to get more languages translated as well. So if anyone's ever interested, we can use the volunteer work.
If I can add just one more insight to this whole opportunity for me in this collaboration, it is really a great collaboration. I love working with you guys, but I did find it quite interesting that, you know, with the times and it being very relevant with COVID, but ironically, it was actually already relevant as we all sort of just rediscovered that a few years back, there's actually been a legal case over a woman who believed she had contracted virus from like makeup at a makeup counter where lots of people shop, lots of people go. And so it was kind of, I think, just the right time to put in that scientific facts and for people to kind of know where they stand. It probably was already a bigger safety concern than it had been made. And then with it just helped push that through. So it's a really important piece of work, I believe, for our safety. So
it's really amazing to me that how people don't realize the infective or just the bacteria nature of cosmetics. I used to work at a Sephora, and even without this information, I was so grossed out when I would watch someone grab a lip gloss off the counter and just stick it on and put it back in the tube. And I'm like, why would you do that? People just don't think. And it comes down to the education. And I'm excited that this is also a platform. Again, like I said, it's not just for artists that are working in the print and film industry. This can be used across so many platforms of artistry, even at counters, and hopefully to inform bigger box stores with their testers and how artists work. We used to use brushes multiple times on multiple talent, and the idea of that now just like makes me ill. So hopefully it's something that we moving forward will be adopted by a lot of other just entities moving forward.
I think there's a minute or so left, so maybe Jeremy, you want to add some final words? Comment?
I just wanted to say thank you all. That it's been a lot of fun and a real pleasure working with you all. It's been such an interesting experience, and everybody on this team has worked so hard and has been so passionate about helping to keep people safe. And it's the fact that this has turned into such a powerful standard that people are sharing and using is just, it's wonderful. So yeah, I'd just like to say thank you all, and thank you all for sharing your experiences and for coming on tonight. And we have just a couple minutes here, so if anybody has any questions, please put them in the chat.
Yeah,
I guess please go ahead, Vincent.
Oh, I was just going to read out one of the questions. The makeup standard might know better than I do, but yeah. It was just, I think Johan was asking, are you impacting other departments on set with the mass doc, I guess?
Oh, yes, absolutely. I mean, depending on the type of set you're on, before I'm booked, I actually send the mass document ahead of time so that they understand what my protocols are for myself. And I say that, I'm like, these are the expectations for myself. And obviously it's going to bleed into other departments or issues. Sometimes I do makeup and hair on a job, so I don't have to worry too much about working, with another artist at the time. But at times when I've had to work with a hairstylist, I mean, at this point, sorry, you need to work over there. And when you're done, I'll take the model and I'll work over here. Or we double mask up, we wear our shields, model stays quiet, and we do our job as quickly as we can. I don't allow anyone within a 6-foot perimeter of my station. I literally tape it out on the floor. And again, I alert the production team ahead of time, because some people have freaked out, like, well, what's going on with you? It's like I'm very standoffish or something. I'm like, this is safety. And people tend to forget. And when you get into these environments, everyone's so free flowing that you really do lose sight of the safety aspect sometimes. So I think that it is definitely bleeding in. And I think as we continue to follow the standards with a bit of strictness, it stands out. Because people realize, like, wow, she's really strict right now, or she's really paying attention to X, Y, Z, and you up the level of people's awareness, and then they kind of follow suit as well.
Kimberly, yes, we are wearing masks indoors at all times.
Absolutely.
Absolutely.
Yes. And I take my lunch outside no matter how cold it is.
Mm-hmm. And
back turned to everyone.
Mm-hmm. Yeah.
There was another question about, are we taking it to the unions and are we approaching the larger corporations like L'Oreal, Mac, Estée Lauder, Clinique? We have, like I said, we have more work that we are still needing to finish for all of our information, kind of like the little details. Do you wear rings when you're working? Do you pull your hair back in a ponytail? You know, those types of things that artists are genuinely asking. So we want to finish the rest of kind of an addendum to this document before we go to unions and everything, because we want to have the whole work completed and not just be like, well, here's half of it, but more is coming. Like, we want to really have it completely confirmed before we go that far.
And I actually have a question to ask here for the group too, which is, do you see after COVID, do you see this standard helping and to define a sanitization standard for the industry as a whole, even after we leave COVID and are sort of just looking at sort of coming back to whatever the new normal is for the industry?
Yes, absolutely. I think that for those who have adopted it, who have embraced the makeup standard and adopted it into their work, I think that it'll be a little difficult for them to just drop the practices, because now we know why we're doing it. So I think for the smart ones, they'll hold on to it. For those who, and I don't mean this to be disparaging to them, but if those who are a little bit lazier, or this has been just a complete burden to have to go through these extra steps and the duration of time that it takes, for it just is a lot longer to be this careful, they may get a little lax about it. But I mean, sure, I have hopes and dreams and goals of where this could go, but it is a very, very steep mountain climb. And we're going up against Goliath with this industry.
And I think it's ironic that it took COVID for, you know, like, I mean, nobody should be sharing mascara or lipstick between multiple talents in one day. So it took COVID to make people realize it's actually more dangerous than, you know, I guess they just never thought about it before.
There's a lot of angles and aspects.
Yeah, and I think just to some of the questions that I'm kind of seeing pop up, you know, the industry that Mary and I are in is not unionized. We're not in the union for film and TV. We are in a large population of artists who work as freelancers. There's no oversight, zero. There are some really dirty makeup artists out there, and they will continue to work for the next 20 years. No one's going to stop them. And even models that get styes or cold sores from dirty product, they don't feel that they even have a voice to try to come after someone. And how would they know exactly who it was that gave it to them? So it is, like I said in the beginning, it's a Wild West scenario, and it really comes down to the integrity of each artist in our community to step up and hold true to these standards.
I mean, in a perfect world, I'm sorry, go ahead, Jeremy.
No, please. I was just I'll go after you.
In a perfect world, there would be a separate sanitation license.
Yeah. Because
the thing about cosmetology licenses is that they're anywhere from 800 to 2,200 hours, depending on what state you're in. And that means that so many things just don't get covered, but the maximum amount of time spent on makeup in any of them is 40 hours, which is a whole other situation. But there are some states where to work as a makeup artist not in our industry, but in the bridal industry, you do have to have that license. So you have to spend, you know, $15,000, $20,000 and 2,200 hours of school to learn to do one thing. So most people just work unlicensed. If there was a separate sanitation license, that would be a much smaller barrier to entry. It wouldn't have to be a 2,000-hour thing. It could be a 40-hour thing or an 80-hour thing. But again, that's something that involves changing politics, we need lobbyists, we need a lot of money and a lot of backing, and you'd have to get the cosmetology schools involved in it. And I've spoken with people on that side of the world, and it is, you think trying to get makeup artists to not double dip is hard.
Exactly.
That's a whole other situation. So yes, in a perfect world, absolutely. In reality, maybe.
So thank you, everyone. This was a great conversation. And unfortunately, we're out of time for the session, but thank you all for coming on tonight. And thank you, everyone, for coming to all the talks tonight. And thank you to all the speakers. I would just like to say this is a great example of so many practices and initiatives that people have done to really try to keep their communities safe. And it's very inspiring to hear everybody's great examples. And I'd also just like to say thank you to everybody in NSVD who have done such tremendous work, and to Kevin for really taking so much charge and committing to so many projects. Every offer that comes onto his plate, he is enthusiastic to promote, and we're just constantly trying to do new projects. So thank you to Kevin, to everybody on the NSVD team, to everybody here tonight. You've all done excellent work, and together we can really keep our communities safe. So thank you all. Please, any questions, follow up on the Slack channel, and we'll see anybody that's interested on the happy hour that starts in about 5 minutes. So thank you all, and have a nice evening.
Thank you.
Thanks. See ya.